Good morning, everybody. It's 8:30, so we'll go ahead and get started with the Healthcare Services Review Project Committee. Today's February 21st, 2024. We'll call the meeting to order. Prior to roll call, I'd like to make it clear for the record of this meeting, and it should be reflected in the minutes, that at least a portion of this Healthcare Services Review Project Committee meeting is conducted pursuant to California Government Code Section 54953, and that committee member Chris Zuniga is at an alternate location of 4860 El Dorado Drive, Laverne, California. Committee member Zuniga is participating via Microsoft Teams in accordance with the Ralph M. Brown Act. Each alternate location has been identified in the notice and agenda for this meeting. Annette Rivas, it would now be appropriate for you to conduct roll call, after which I will ask committee member Zuniga to recognize me in order to confirm certain matters for the record. Thank you. Annette.
Supervisor Canepa.
Here.
Supervisor Dean.
Here.
County Administrator Wilverding. Ms. Hopkins.
Here.
Ms. Van Stein.
Here.
County Counsel Kiernan.
Here.
Ms. Macedo. Mr. Wolfkamp. Mr. Diedrich.
Here.
Mr. Castro.
Here.
Mr. Nunez.
Here.
Mr. Zuniga.
Thank you, Annette. Committee member Zuniga, I will now ask that you respond to the following questions. Mr. Zuniga, can you hear me well?
Yes.
Were you able to hear our proceedings on this end up until now?
Yes,
Do you have a copy of the agenda?
I do.
Have you posted the agenda at the location where you are?
Yes.
Is your location reasonably accessible to the public such that any member of the public could participate in this teleconference from your location if they wish to do so?
Yes.
Is there any member of the public there with you who would like to participate in the public comment portion of this meeting or any other agenda item?
No, there is not.
Thank you. I would now like to ask that any member of the Healthcare Services Review Project Committee speak up at this time if such committee member has not been able to clearly hear Committee Member Zuniga. Hearing no comment, the record should reflect that all committee members present have indicated they were able to hear Committee Member Zuniga clearly. I would next request that any committee member speak up at this time if such committee member has a reason to believe, based on voice recognition or otherwise, that those persons representing themselves to be committee member Ziga are not truly so. Again, hearing no comment, the record should reflect that no committee member has expressed doubt that committee member Zuniga is the party participating by teleconference with the committee members present here. So thank you for that. I would like to now advise committee members that any votes taken during the teleconference portion of this meeting must be taken by roll call. Ms. Rivas will be conducting our roll call. And moving on to the next agenda minute item, please approve the minutes from January 17th of 2024, and I'll need a motion to approve and a second.
moved.
Do we have a second? Thank you. Ms. Rivas?
Supervisor Canepa,
Yes.
Supervisor Dean,
Yes.
Ms. Hopkins,
Yes.
Ms. Van Stein,
Yes.
County Counsel Kiernan,
Yes.
Mr. Diedrich,
Yes.
Mr. Castro,
Yes.
Mr. Nunes,
Yes.
Mr. Zuniga.
Yes.
Thank you to all of our committee members. We're now moving on to information and discussion items. And our first discussion item will be to present the 2023 financial results through December for our county clinics by Mr. Zuniga, and he has the presentation up on the screen. Thank you, Mr. Zuniga.
As a result, I'm hearing myself again. Could everyone please turn their mics off? I'll just continue, and if it's not a problem for you, just keep going. But we have a $1.4 million adjustment for our net patient service revenue, and that is resulting in an 834,000 favorable revenue variance. And we can see that on the year, it has caught us up quite a bit as compared to other months that we have seen. So 11.6 million against 11.9 million budget. We're running an unfavorable budget variance of 362,000. One other revenue that I'd like to point out is the $500,000 managed care incentive we were able to recognize in December. That is also aiding our fiscal results for the month. These are unbudgeted incentive dollars, and so they are flowing through right to the bottom line. Total operating revenue are 5.2 million against a budget of $4 million. So that's a favorable revenue variance of 1.1 million. A year-to-date basis, we're at 24.5 million against 24.7 million. So right in line with expectations from a macro level. On the expense side, salaries and wages were under budget by about $500,000 when we include benefits. Professional fees are in line with expectation. We do have enough expenses for dues, subscription and fees, and that's largely due to our CVS contract associated with our 340 pharmacy program. So as a whole, we have 3.5 million in monthly expenditures against a budgeted $4 million. So we came in well under budget for the month on the expense side. Our net income for the month is 1.7 million against a budgeted. So almost all of the net income for the month represents a favorable budget variance of 1.6 million. On a year-to-date basis, the results from December have reversed the previously reported net loss for SJ Health, and we are now running net income of 1.2 million against a budget year-to-date revenue, income of 565,000. So have a favorable of 800,000.
Mr. Zuniga, I'm going to pause you for a minute because your microphone is cutting out. And so I'm not sure if you're close to your microphone or if we need to switch over and ask Mr. Diederich to run the rest of the presentation. I'm not sure if our committee members are experiencing the same cutout.
I am definitely hearing myself twice.
Okay.
So I'm having to pause so that I can hear myself stop talking, and then I sort of resume.
Mr. Diederich, how would you like to proceed?
I don't know if, I could take over. I don't know if it's too obnoxious. And Chris, I don't know if maybe if you just turn off your mic and assume we can hear you, rather than have your speakers echo.
My speakerphone and my speaker are one and the same. So
Okay, I think it may be best for the Brown Act requirements to have Mr. Zeter take over and finish the presentation so it doesn't keep cutting out.
Well, Chris, can you advance to the next slide?
So the previous slide was the P&L, and now we've got the MOU breakout. Would you like me to?
Oh, I'm
uh,
sorry.
continue?
I'm looking at my screen here that didn't advance. My apologies. Yeah, so this is an MOU breakout, and I generally don't like this particular slide because I keep mentioning the SJ Health Board that we are the health center, that is a collective of the county and the nonprofit together, not us individually. I think it's a little contrived that the net patient revenue is setting on SJ Health on this column versus the county. I think it's arbitrary, but this is kind of a breakdown of the different components of the MOU. So next slide. Here are the variances from actual to budget for the current period if they exceed 10%. As Chris mentioned, we did have a favorable pickup for the HEDIS measures from the Health Plan of San Joaquin. Grant revenues still underperform. A lot of that has to do with when we can compliantly recognize the revenue. So on a positive note, it's not like we can't eventually recognize the revenue. We've done some grant extensions to make sure that we can actually capture the revenue. And some of these are the budget for these are flat over the year, whereas I think most of these grants, some of them have triggering events where if you do an activity, it will trigger the revenue recognition. It's not always simply based on reimbursements. As Chris mentioned, some favorability with our 340B complement program. And I think other items on here, as mentioned in the past, employee benefits will continue to trend positive to budget throughout the rest of the year because of the way that we built our budget, which is we have lower overall employee benefit load than what was budgeted, and that will continue to reflect. The professional fees are unfavorable, and that's the locum cost. Chris did mention, I think when we report on our January financials, you'll see a substantial uptick in visits. Where we are for the month of January, almost at the budgeted visits, and that's substantially due to the locums we've acquired, as well as some other county employed mid-levels that are coming on board. And dues and subscriptions unfavorable. We would some one-time licensing costs and such. Next slide, please, Chris. Here's our balance sheet, and I think it's still a very strong balance sheet. You can see our cash equivalents, and our total assets. So we have an ability to maintain operations for the foreseeable future, given that our P&L is in the positive now. Next slide, Chris. The cash collections trends are our visit volume, and you can see because of the historical visits over the last couple of months being lower, cash is also low. I'd like to point out at the bottom of the slide our patient mix. The vast majority of them are the managed care medical plans, Health Plan of San Joaquin and Health Net. Some fee-for-service, and those are individuals. California is greatly a managed care state, but we have people that just acquired Medi-Cal, it would be fee-for-service for a month and a half, people leaving incarceration, some of the foster care children. And then the other payer is Medicare, very little self-pay or commercial pay. And I think that will become even less because of January 1st of this year, the residual uninsured, undocumented population between the ages of 26 and 50 have state-only Medi-Cal eligibility. Next slide, please. This is kind of a consolidation of the visit trends in the cash collection and how they trend together. Next slide. Again, this is our some of the measures we report to HRSA, and you can see that our average cost per medical visit is $356. That will continue to stabilize during the year, but I would point out that is probably on the order of $60 per visit above our average PPS rate. And the cumulative cost per patient visits will continue to trend down as we add more cost to the numerator, but that will continue to trend up as we add more cost to the numerator and fewer net additional patients. for that calculation for the fiscal year. Next slide. These are the 5 industry key metrics that we report on and benchmarking against our peer group. Next slide, Chris. And as Chris mentioned, the prior 6 or 5 months of this year, we had 3 of these in the red. Now we have only 1 in the red, and that's our personnel-related expenses, which is well above the benchmark. I think we have some opportunity there, so we have a lot of fixed costs with the labor, but all the other ones are now solid, and I would say the days cash on hand and the net patient receivables are very solid. Next slide, please, Chris. And with that, question and answers, and hopefully Chris is a lot closer to some of these reporting details, and I'm just, but with that, Brandy?
Thank you. Are there any questions or comments from the committee?
Yes,
Microphone, please.
it's on.
Oh, doesn't look like it's on.
green.
Thank you. Supervisor Dane.
Okay. The biggest variable to me that pops out here is personnel. And then just a clarification on, you said we're beginning our recruitment process for physicians. You mean we're beginning to see progress, or we haven't even started yet? And then the second, to follow up on that, you've got a $1.4 million decrease in benefits, obviously, because we need physicians. But yet we're gonna start the recruitment. But Greg, you just said that we expect that trend to continue on the benefits line. We actually wanna see that go away, right? Cause we wanna see physicians hired, which, I mean, that's your big variable here between 900,000 and 1.4 million just on insurance.
So for the first question, the recruitment is very much ongoing. We engage with a variety of locum firms. We do recruitment. It's ongoing. Dr. Dooley actually has probably 3 to 4 interviews per week. So it is very much ongoing. My comment was that in January, we did staff the Manteca Clinic kind of full. We went from 1 provider to 5 providers. And that will be the uptick. So when we report on January, our visits for January will be very close to what was budgeted, whereas right now we look to try to get about 460 visits per business day. We've been trending about 100 plus below that. We're going to be very close to that in January, and that's because of the locums. But our goal ultimately is to replace locums with permanent physicians. And we are partnering with the Health Plan of San Joaquin. We are signing an incentive program with them that is eligible for basically FQ safety nets. But I'm working to see if it will flow through the county or if it will flow directly from the health plan. But that will be a substantial dollar amount for our recruitment and retention of providers. So our goal is long-term providers. But your question on the benefits, that will pick up when we hire more people and people are employed versus locum or a 1090, a service rather than a salary. But my overall point is that when we budgeted benefits, we budgeted them at approximately, I want to say 60% of salaries when they're coming in much lower. So it's not strictly that we don't have enough employed people. I think we do. The distinction is the way that we were the way that we had to apply the benefit load might be more applicable for other areas of the county. Maybe we have more tier 2 retirees, but that trend will continue simply because it's a known budget variance that our internal projections was we were going to spend a lot less on benefits, but because of the way that the budget is created in the PeopleSoft system, these were the percentages we were forced to use.
Great, very good, thank you.
Supervisor Ding, the county administrator's office is engaging in SJ Health conversations to look at the benefits piece as well. So if we have a report out, we'll bring it to you. Okay, are there any other questions or comments related to the clinics? Supervisor Canepa?
So the locum, so when you lose that many patients in the past months, how does that, so you need to get more the next month? Or, I mean, you're just trying to achieve budgeted. So where's the budgeted number come from about how many people?
So the budgeted number is based upon what we have expected for our providers, either providers we have or the providers we're expected to recruit. We generally like to have 3 billable patient visits per provider hour. So we build the budget up from that bottom basis. But because of some turnover in providers, because of some productivity issues, we've not been able to achieve those budgeted numbers. When we entered the budget, we projected Manteca to be basically from July 1st at full volume. That they have not been, but in the month of January finally got to where they were at full volume. We are still experiencing some turnover with some of the providers, but we are backfilling with locums, and I know we are bringing several permanent provider recruitment contracts to the board as well.
Okay, so over November and December, those numbers, so you're basically 5,000 visits short. So that's year to date is the 8260.
Correct, and if you look at that slide where you have the 5 months broken out, the December one will be a low 3-digit variant number.
January will be.
Yes, versus some of the last couple of months are there in the couple thousands.
So we'll never be able to catch those visits back. I mean, we just got to get back to budgeted.
Oh,
is the goal.
our goal is on a go forward to be close to budget. We will never recapture the 8,000 visits that we didn't achieve in the first 6 months of the year.
Okay, thank you.
Okay. Any other questions? If none, we will move on to our next information and discussion item, which is the presentation of the 2023 financial results through December for San Joaquin General Hospital, and Mr. Nunez is going to provide that. Looks like we're switching over. We'll get you the clicker.
Good morning, everyone. So we're going to dive into the hospital's financial results through the first half of the fiscal year. The story is very similar to what was shared last month. From a profitability perspective, our net income is $2 million short of target. And when we look at our financial results from a cash flow or EBITDA viewpoint, we're $1.3 million short of where we expect it to be. In terms of the key drivers for the less than anticipated results, I would point to 2 items. One is a contraction in our inpatient business. When we look at both our patient days and discharges, those metrics have come in lower than last year and lower than target. And we have to consider that the revenues generated by our inpatient services carry a much higher collections rate than our outpatient services, just based on the way our contracts are structured with the various payers and the health plan. And then the second item is our traveler
Excuse me,
costs.
committee. I apologize for interrupting. However, the hospital's presentation is not visible to me, so I'm wondering if it's visible for the recording.
Thank you, Mr. Zuniga. We're going to pause for 1 minute while our IT team looks into that.
I can see it now.
Thank you.
Okay, so we were getting into the 2 key drivers for the less than expected results. So the contraction in our inpatient business, we talked about. The second item is our traveler cost. This year, we set a very aggressive savings target in our budget in anticipation of bringing in some foreign nurses, which hasn't materialized. With that said, year over year, we're seeing a considerable decrease in our overall contract labor. When you combine both our professional and purchase services through the first 6 months of this year versus same time last year, those costs have come down by roughly $8 million or 14%. So we're really doing an admirable job just vetting any new contractors that we hire to fill any gaps there within both our clinical and non-clinical teams. Moving forward, we really need to kind of identify and realize opportunities within our internal labor And that's where we'll need support from the county office in terms of being able to flex staff when volumes dip, or having an absentee policy, which we've been trying to get approved for some time.
I just like to add that we onboarded in the last 2 months over 70 registered nurses. And this has been our history. We're very excited about the fact that we onboarded 70 nurses. We also had a survey done, a employee satisfaction survey, and our biggest loss of employees come from years 1 to 3. As we have been talking about the union contract and the need to focus on those first 3 years, it's really, really important to us, because that turnover, the fact that we've hired 70 nurses is a great thing. Now we're spending the next 4 months, next 6 months training those 70 nurses, and if we lose them at month 9, if we lose them at year 1, we're spinning our wheels, and that continues to be a challenge for us. Again, we're very proud of the significant dent we've made in the travelers. The reason that the budget is, there's a variance from the budget. If you remember, Brandy, the expectation was we were going to bring in 50 international nurses at the same time. It all looked very positive until the devil's always in the details, and the details in the contract were not quite as good as the challenges. And then in addition to that, the government has stepped up from the places that we were looking for and made it a little bit more difficult. I bring this up because April is the CNA negotiations, really, really important to us. And the opportunity, if you look at all of the data and what we've discussed in the past, the opportunity needs to be focused on 3 things. How do we keep those 1 to 3 year nurses? So let's do let's focus on that piece of the nursing, because that's where the turnover is highest. That's issue number 1. Issue number 2, which I think definitely needs to be a hospital issue. I believe it should be a county issue. We have to have a policy for absenteeism that makes sense. Doesn't need to be draconian, but it has to make sense. When you look at our sick calls versus the public sick calls, the number's somewhere around $15 million. $15 million. 1 in 4 to 1 in 5 of our employees calling sick every single day with 0 ramifications, 0. And when we challenge them on those issues, the union comes in, as they should, but I believe it's a misrepresentation of what sick time is versus what PTO is. So it's really important that we focus on that 1 to 3 or 0 to 3 years. It's really important that we have the ability to hold accountable and do a better job in our sick time policy. And the third piece of it is, we have to have the ability to flex, right? It's not like we compete with other hospitals. We don't compete with other counties. And the difference between us and Sutter, and the difference between us and even Kaiser, and the difference between us and Joe's is when we have no work, we still have to have employees. When they, for example, I use the NICU unit. NICU has been good lately, but when it did drop to 3, we had 7 nurses in there. There's nothing we could do about it. And it's not good patient care, it's not good for morale, it's not good for all those things. So I understand now, as I've been doing this about a year and 8 months, I understand there's differences between the public and the private sector. And I understand also that things are going to take a little bit longer. You know, you've all brought us here as part of the MSA to make sure that we are, number 1, better in quality. We're making sure that happens. We want to be fiscally responsible as well, but the tools that are available to the private sector and to the not-for-profit sector are not available to us, and that is a decision that we've all made, as opposed to any law or, you know, it's not, it's an option that we chose not to take. Keep going.
So, yeah, thanks, Rick. So while we're short of target, we feel confident at this point that we'll be able to realize some opportunities to close some of the budget shortfall as we progress through the rest of the fiscal year. Looking at our overall volume metrics, so looking at the whole house, looking at adjusted patient days, so that's a combination of our inpatient days plus outpatient equivalent days. We're short of target by roughly 1%. So while our inpatient revenues are lower, which correlate with the lower discharges and days, we've made up for that shortfall through an increase in our outpatient business. Some other positives, when we look at our maternal child department, doing really well. That service line is trending in the right direction for us. Our CMI, or case mix index, we're seeing a spike in terms of how we're coding those inpatient claims, which is driving up our revenue line and minimizing denials from our payers now that we're more accurately coding for those services. Length of stay has been a little problematic here in the last couple of months, which is kind of driving our overall cost per CMI adjusted discharge above target. But in meeting with the case management team, I know that they're working with our providers on ensuring that we are monitoring those patients earlier in the day and discharging them as soon as they're medically cleared. When we look at total revenues, we are favorable to budget by about 1.2% or $2.8 million. I think this is a good result considering that our inpatient business has declined as mentioned. So our net patient revenue from our core services is running favorable, but in terms of the revenue recognition connected with our incentive programs, those are below budget due to some of those quality metrics not being where we would like them to be. And on the expense side, when you look at the breakout of the budget variance by expense category, it's really the professional services or the travelers that are driving that unfavorable variance. Here's a condensed version of our income statement. You can see that for the month of December, we were short of our net income target by about $90,000. Year to date, as mentioned, we're short by $2 million, and from an EBITDA or cash flow perspective, we're $1.3 million lower than expected. Here's the more detailed version of our income statement. When we look at the top section or the revenue line, gross revenues are about 2.3% higher than expected, but it's all on the outpatient side, which carries a much lower collections rate relative to our inpatient services. And that's the reason why the net patient revenue variance to budget is lower than the gross because of the change in our service mix. And then you can see when we look at the additional funding where we track the revenue connected with our supplemental programs, those revenues are short of target by 1.6 million. So we're being more judicious in how we recognize the revenue due to the quality metrics shortfall. On the expense side, total expenses are over budget by 4.8 million. And you can see the professional fees, second line on the expense section is driving that negative variance. Supplies are over our fixed budget, but we have a revenue offset in that our surgeries are high. Our outpatient surgeries in particular are much higher than what we expected when we initially planned for this fiscal year. So there's a revenue offset for that higher supply variance. Purchase services, a considerable positive variance in that line. Some of that has to do with the timing of some of the projects that we anticipated to implement this year. The 3M computer-assisted coding comes to mind. Here's a snapshot of our balance sheet. Year over year, you can see that our cash balance has dipped by about 31 million. But that's due to the timing of our incentive program payments. This month, we'll have to put up another 22 million electronic funds transfer connected with the QIP program. But in 30 days, we'll get 40, 50 million. So we expect that cash balance will pick up here as we progress through the end of the fiscal year.
So for understanding it from a supervisor perspective, a lot of these programs require us to put money up front to get oftentimes double the money back. So that's what he's talking about. When you look at that 30 million that he's discussing, it'll go in from a quality perspective, and we'll get in the following months much more than that back, and it's that scenario of how they divvy up the funds. Does that make sense?
Yeah, the swings in a public hospital's cash balance are much higher than a private hospital because of these incentive programs making up 25% of our revenues and the timing associated with those cash transactions. This one, here's our financial dashboard, which measures key volume and financial indicators. Kind of an eye chart, but overall, when you look at the first line, you can see our discharges 5.5% lower than target. When you look at our total contractor FTEs, you can see considerably above the very ambitious target that we established in this year's budget. Here's a few key volume graphs. On the top section, you can see our adult business. On the top left, our patient days, top right, discharges. Blue line is current year, red is budget, green is prior year. And you can see that the blue line has consistently come in below both target and prior year levels through the first 6 months. Down at the bottom left, you can see that our average length of stay for the current year is the blue. We were relatively on budget through the first 5 months, but you could see in the month of December, we shot up. But I know that our case management team is working diligently with our providers on bringing down those.
Some of the times when you see peaks like that, it may be simply that we discharge a patient that had been here for 4.5 months, 5 months. And then it goes into the, obviously it goes into the numerator.
Yeah.
And makes that length of stay very, very difficult.
And there's some seasonality there as well. You could see that last December, our length of stay also shot up. And then on the bottom right, you can see our maternal child service line, our deliveries. So the blue line current year, for the most part, has consistently come in above prior year level and target.
I have a quick question. So back to the average length of stay. So you have people for months?
When I first got here, we had somebody here for 762 days. And
So how do you
well,
average
you know,
that in your numbers?
So there are certain things, like for the 700-day person, you know, we were debating whether or not to spend $12,000 on an air ambulance. And so I said, yes, we're going to spend $12,000 on an air ambulance because otherwise he's going to be here for the rest of his life. So we had a number of them when we first came, a significant number in the greater than 100 days. We discharged all of them. We continue to focus on it. There are circumstances sometimes where there just is not a good answer. And the typical scenario that is a challenge for everybody is that 600-pound patient. There's no easy way to transfer that patient. There's from the post-acute side, they understand that somebody with those kind of issues will take their bed for as long as they typically live. So it becomes a challenge. And what we try to do with the post-acutes to keep our patients moving is we try to make sure for every challenged patient that they get, they also get a number of good patients. So there's a relationship to say, look, we're not just going to send you the patient that you're not going to be able to discharge, or we're going to send you a number of Medicare patients and a number of good patients to make up for it. This is a challenge for all the hospitals, although we always need to focus on those really long patients and find a better way, even if there's a significant expense on the front side.
A few more volume graphs. You can see that our surgeries have been a good story. When you look at the blue line, consistently exceeded prior year and budget. On the bottom left, our trauma cases, they did dip in the month of December, but overall we're pretty much where we expected to be. On the bottom right, our ED visits, while we are unfavorable to budget from a year-to-date viewpoint, it was good to see those visits pick back up in the month of December. Here's a couple of metrics that kind of gauge our performance in our billing and collections. When you look at our cash collections, top chart, blue line is current year, orange is prior year. You can see that for the most part we've been over prior year level, which we expect, which I feel is a good result. Well, considering that we're collecting on less inpatients, which drive a high percentage of our revenues. And that's due to a lot of initiatives within our revenue cycle to lift revenue outside of volume growth. So coding, charge capture, strategic pricing, all those items are contributing to the pickup in cash collections and revenue. And down at the bottom chart, when you look at our AR days, we ended last year at 96 days As of January, we're at 91 days in our AR. We want to get to at least 80 days by the end of the fiscal year. So definitely challenging our billing and collections team to improve our current state. And then we talked about the swings on the days cash on hand just due to the timing of the receipts of our incentive programs. When we look at our acuity level of the patients that we've treated this year, this is a good story. You know, we talked about the launch of our clinical documentation improvement team this year, and you can see that those added resources are paying dividends. When you look at the case mix index associated with our Medicare patients, we ended last year at 1.89. This year we're running over 2, which, you know, is driving our revenue line up. And when we look at the CMI connected with our all payers and our CDCR, our prison patients, that acuity level has also picked up.
So just really importantly, this was one of the MSA initiatives. And I want just from a supervisor perspective, because these are probably numbers you're not used to seeing. These CMI numbers, every 1/10% represents hundreds of thousands of dollars. So it's really more money on the same business when you look at the CMI year over year. That 1.8 to 2.04 represents millions of dollars based on the same volume that we you know, even on a lesser volume. So it's really important just to point out this is one of our big focuses. And when you look at the 2 categories where you see it significantly higher, both the CDCR and the Medicare, those are the payers that pay based on that acuity. So that's where the focus should be, that's where it has been, and those numbers represent, you know, significant dollars to our bottom line.
So Rick, what you're saying is you've always seen these patients, but now you're proving the acuity of them and the complexity in getting the reimbursement you should have been getting.
The best example is the pneumonia patient, pneumonia versus sepsis, 13,000 versus 40,000. We were coding most of them. Most patients don't come into the hospital for pneumonia, it's just they don't. They have an infection. As long as there's a source, it's really the true diagnosis is sepsis. So that same patient, if they were a pneumonia patient, 3-day length of stay is the geometric mean, $14,000 is the reimbursement. Same patient, coded correctly, geometric length of stay is 5 days, and the reimbursement is about $40,000. So you see the significant difference in those numbers. 40 might be too high. It might be, anyway, significantly different, 3 to 4 times the amount of reimbursement.
Yeah. By not coding these patients appropriately based on the level of care provided, we left a lot of revenue on the table in previous years.
So can you clarify the colors, why the discrepancy in the colors? So you have acute, I don't understand.
Yeah.
So what number is better?
Higher is better.
Higher is
The
better?
way, if you look at the 3 of these, so only Medicare and CDCR pay specifically on acuity, not only, but most payers do. If you look at the bottom line where that CMI is 1.644, the reason that it's low is because a lot of those patients are labor and delivery patients that typically have a CMI of 1. They're in and out in very small times. That's the so the crux of this slide is to say the 2 areas that are most important for coding are being very positively affected by the way that we're coding. When you look at the general, it has gone up, but it's not. It's kind of less significant because most of those are not CMI related payments.
So you're saying the ones that are basically in and out cost less?
Oh, absolutely, yeah,
right,
yeah,
right.
yeah. If you assume the cost of a patient day is about $2,200, so any less patient day, labor and delivery patient in and out 1 day, maybe 2 days.
So then coding them is the most important part, and this number represents the coding of it.
This represents. I think what this slide is showing you is the coding metrics that we've put in place are working as we planned. And you see that by the fact that even our non-Medicare patients are more complex, so there's some dollar value there, but nothing compared to the dollar value of our CDCR patients who pay Medicare plus 30%. So those numbers are really important. And then our Medicare patients overall. So that's where the reimbursement is coming significantly higher in the areas that it can.
Okay, so the goal is to trend all of these numbers closer to the 2.0?
Well,
mean,
you're
what's
never
what's the
you're never
goal?
gonna get, you're never gonna get the overall,
The blue line will never get that high.
never get that high. But the places that it makes the most difference, both Medicare and CDCR, which are Medicare, primed payers, that's where it makes the most difference. That's where we're seeing the biggest improvement.
Okay, thank you.
And here's a slide which measures the cost structure for the hospital. So it takes our cost per volume measurement normalized for acuity. So it's a metric that private hospitals use to kind of benchmark and evaluate their cost structure relative to other hospitals similar in size and acuity level. Year to date, we're pretty much right where we expected. Our cost per CMI is running at $15,352 versus a budget of $15,004. This is going to be even more important as we go forward in that in our correspondence with CAPH, some of the incentive programs are going to be tied to cost measurements as we go forward. So we're going to be forced to be more efficient in order to realize, 100% of those revenues connected with those programs moving forward. We don't know how those cost measurements are going to look like. They're still kind of developing them, but we'll bring awareness once we know how that looks.
Quick question, how'd you get that back down? So obviously November was
Yeah,
considerably higher.
Yeah, the reason it's gone up the last couple of months is due to a decrease in our inpatient discharges and our length of stay. We talked about our length of stay, which is driving the costs associated with those patients.
Thank you.
And then this is a good story. When we look at our contract labor, we talked about the considerable decrease in those dollars year over year. We're at 160 contractors last December. We're down to 120 this December. So that's a 25% decrease, which we're seeing on the expense side when we look at our year over year income statement.
Really importantly, these numbers reflect total contract labor. We're focused on nursing, we're focused on respiratory, we're focused on the professional side of it. We have a significant number of employees in contract labor, both in the dietary department and the EVS department, simply because our wages are less than in and out. I don't know how else to tell you that, but we're very challenged in that number, but we're less concerned about it because the overall cost for a traveling nurse is significant. But compared to what we would pay for our own employees, when you look at it on the more on the lower labor side, there is no additional cost. If we have to pay, for example, $30 an hour for a EVS staff, it's very close to what we actually pay when you include the total cost of that employee from a benefits perspective. Does that make sense?
Yeah, the contracted registered nurses really drive the dollars when you look at the overall.
So what we'll do next time, I think would be a good metric here, is we will show the overall number, but we'll also show the nurse number and the areas that we're really focused on making those changes.
So the goal, so when you do obviously the one line, the actual, what's the goal of that?
Well, goal would be zero. The goal would be to have our own staff.
Yeah.
But all those other variables in contract negotiations would have to take effect.
Well,
to
again, we've had significant pickups recently. When we were January of 2023, we just weren't getting applicants. We weren't getting applicants. We weren't being able. It's not that we weren't able to hire. We just had no one coming to the door. And the example that they shared with me was when we did the new nurse recruitment. We typically got about 500 applications. When we did it in 2023, we got 60. So that trend is now coming back in our favor. That's good news. We just told you 60, 70 nurses are on the docket right now. The challenge will be to make sure that we do everything we can to keep those nurses. That's the challenge. And we talk about, we did an employee satisfaction survey because I think it's important that you do that. And it did show that there's our gap, man. If you're here greater than 3 years, your likelihood of staying is significant. 1 to 3 years, that's where our highest turnover is. So that's obviously the place we need to focus.
So then do you look at the cost of training and recruitment and all of that?
All of that all of that is baked in here, because the other thing that we don't separate here, which, you know, what I'm used to is a number of significant costs, and one of them is orientation. We don't break that out here, but I'm sure, or I think about it right now, we have 70 nurses in the pipeline, all working for us for the next 4 months at a complete cost, not, right, right. They're not providing any real labor because they're precepting their training. So I suspect when we break out our orientation costs, it's gonna be a big opportunity for us. So that reason that we say we need to focus on retention and is exactly what I'm talking about. It's not just the cost of bringing in a traveler, it's all the additional costs that go with it.
Because I mean, basically, yeah, it's 2 to 1, right, while
Yeah,
you're training.
2 to 1,
So
exactly.
you have 2 people.
Yeah, it's a.
Per job.
Yeah, essentially, we're making an investment, right? But now we have to figure out ways to.
Yeah, you don't want to be the training mill.
Yes, exactly.
But we kind of are.
Just to add, I mean, in our industry, you will always rely on some level of contractors to fill gaps within your operation. I mean, I came from Stanford, where the cost and wage structure is probably one of the highest of all large academics, and even Stanford relied on some contractors to fill gaps.
But they have $2 billion in their foundation, so they don't really
Yeah,
have to
yeah,
worry
yeah.
about it, right?
Do they need a stepchild?
I already applied for that position, they don't need it.
And here's the dollars connected with the decrease in our contractors year over year. You could see that our peak was 2022, we're at 82 million. Last year, that number came down to 63 million. This year, when we look at the first 6 months times 2, you know, we're trending at 46 million. So very strong progress within the hospital team of really vetting any new contractors that come on board. And as Rick alluded to, we're doing a good job now bringing in full-time employees. Okay, in terms of opportunities, we talked about the budget shortfall through the first 6 months. I know Greg is working on, with his team, on bringing up our QIP quality metrics. When we look at the total QIP for our health system, it's roughly 80 million. If we do the quick math, if we come in at 75% of those metrics, we're essentially leaving 20 million on the table, right? So I think we have a huge opportunity there as we go forward. EPP supplemental program, in our correspondence with CAPH, they were able to secure a 25% increase effective January of this calendar year. So that's gonna bring in about $4 million annually, so $2 million higher revenue will hit the books this year. We worked with Lizeth on a rate increase from the health plan, so that's gonna bring in a couple more million in the last 6 months of the year. Continued to engage with our Cerner EHR team on finding ways to automate some of our workflows within our revenue cycle teams, so that the team can focus more on the analytics and the high ROI accounts to ensure we're not leaving any revenue on the table. Cost, you know, we continue to kind of bring down the traveler nurse to closer to target. I know it was a very ambitious target that we established, but year over year, you could see we made good headway there. Our materials management director is working on implementing a new tool to track our high-cost surgical supplies in both the OR and cath lab. This tool is also going to help us with optimizing par levels and productivity improvements, so that's another positive for us. And then reference lab savings, finding ways to kind of get better rates from Quest on those send-outs, and really figuring out ways to do more of those tests in-house, you know, to minimize those costs.
So I'd like to do a little summary for the board members. You know, we're about $1.3 million behind budget EBITDA-wise. We're very comfortable, not kind of comfortable, we're very comfortable that we have some pickups coming our way, we have some increased reimbursement coming our way. We're very comfortable that we are going to hit our targets by the end of the year. So I hope that gives you some reassurance. With that being said, those metrics, the reason that we are, in a sense, getting there is a bunch of pickups from past things that were not done correctly that we've identified and are getting paid back for. And if you look at our run rate, I'm also very comfortable with the fact that we can operate in the positive if we do one thing. If we start collaborating as a health system, as opposed to 3 individual, 4 individual silos, as we're doing right now. And I say that, I can give you all kinds of different examples. It's very important for us that we, that we maximize our designated public funds. When we leave $20 million on the table, that should be concerning to all of us. And I'm just not comfortable that we put steps in place to realize more of that. And I say that because the gap between us and the other public hospitals is significant, right? Everybody else performed 95% or better. And I know we're doing everything we can to get there, but I'll give you the most recent example of us not working together as a system, almost competing against each other. We developed with the health plan lab policies that don't make any sense. It was, again, before we realized it. No accusations here, but we have a set of patients that are intermingled, right? Patients that go to the FQ clinics also come to the specialty clinics at the hospital. So the lab contract was set up so that people that were assigned to the clinics went to Quest, and people that were assigned to the hospital went to the hospital, and it was a capitation rate. So we got so much per member per month. Let's just say it was 200,000 patients. We had 60,000, and Quest had 140. Well, every time a health plan patient comes to the hospital and needs lab tests, we do them, assuming they're part of that capitation. So what ended up really happening is the hospital took the brunt of the contract. We know that we looked at a Quest bill, for example. Our typical Quest bill runs about $100,000 a month. That's for tests that we can't do in the hospital. And then when we did an analysis of that bill, we found out that over 50% of those patients were indeed San Joaquin Health Clinic patients that should have been capitated to Quest. So Quest got paid for them on the front side, and then secondly, Quest got paid for us on the backside to the tune of the damage to the hospital between that and the public health debacle is about $2 million. And we don't sit down, we talked about this at the last meeting, we should sit down as a health system. Forget the arbitrary silos that we've wrapped around ourselves. We should sit down as a health system. How can we recruit physicians that would be more beneficial if maybe they want to do inpatient and outpatient, right? If they go to San Joaquin Health, they're offered an outpatient position. If they go to the hospital, they're offered an inpatient position. Maybe they want a combination of both, and that gives us the ability to recruit more people as opposed to less. So I stress this because, we need to do better in public funds. There's no question about it, and I hope we're all in agreement with that, and I think we are, and we're working hard to do that, but there's still a big gap there. We need to do better working together as a system. We're leaving too much money on the table in hopes that our balance sheet looks good as opposed to the overall balance sheet looking better for the whole county. And I've been saying that now for 18 months. I know we're going to hit our targets this year. I'm very comfortable with that. We're not going to continue to hit our targets, or we're not going to continue to operate in the black if we don't take advantage of every opportunity that's out there. It's tough with the Medi-Cal business. First time in my life where outpatient business is not desirable, because the outpatient business is our true Medi-Cal business. We get a lot of Medicare from our trauma center, which gives us a better return on that money. But when you look at straight Medi-Cal on an outpatient side, it's 9 cents on the dollar. And so the more that we do some of these things, sometimes the more that we spend. And the nirvana is to find a way to manage these patients in the most cost-effective way possible that's going to benefit the health plan, it's going to fit the hospital, it's going to benefit the clinics. We're not there yet.
So I have a quick question. So of those variables that you were talking about, I mean, that's the thing that you're talking about. The cost savings that you've been doing only is gonna last so long. So cleaning up the mess.
Well,
I mean, so I mean, the coding, you know what I mean, the billables, you know, tightening all that, right? I mean, that's what got you to where you're at now. So I mean, it's only gonna work for so long until we find out what the best way to do how everything's combined. And I mean, that's the struggle with, you know, Supervisor Ding and myself, is we're just learning all this, and it's very difficult to learn all this. And then, you know what I mean, with the clinics and how we're gonna go forward. So I mean, that's, I think, what the next plan of attack
Yeah.
is obviously how to strengthen up these, you know, and I don't want a PERB, you know, violation going against us for unfair labor practices, but I mean, those are obviously variables that come into it. You know, tightening it up so that you don't have 42 people gone on Halloween. I mean, that's alarming. You don't have 1 in 4, because that drives your cost of your traveler. I mean, and I get it. So, I mean, you have to have tools. I know we're not competing with private agencies, but at the same time, we are competing against private agencies because we're forced to.
Yeah, I mean, there are
So I mean,
considerable, when you look at our cost in our industry, considerable pressures, right? We don't know yet where the new contract with our physicians is gonna land at. You know, the CNA contract is coming up. We know our cost line is gonna go up. So what are we doing to be more efficient and more integrated as a health system, so we can eliminate redundancy? I mean, that should be our overall objective.
Supervisor Canepa, thank you for your comments. And I think when you listen to both departments who presented today, they're both talking about just what you said, working internally within their own department to tighten things up, be more efficient and effective to provide community health to our population. And then what Mr. Castro's talking about is recently, Mr. Castro, Mr. Diedrich, and I have had a couple conversations about getting the entire system together. You've heard Mr. Castro talk about that in some of these meetings. So the hospital, the clinic system, the health plan of San Joaquin, and really trying to do some strategic planning to make sure things like this lab example that Mr. Castro provided isn't occurring, to ensure that patients are out of the ER and in the clinic when they're supposed to be, all of those variables to support community health in the most efficient way possible. So we will be setting up a series of meetings and then ongoing meetings to ensure that we're working together as an entire health system.
well, yeah, that's the hardest part, because you get lay people on these boards. You know what I mean? And it's difficult to learn this. I mean, and I don't know what the education on the outside boards is, but I mean, it's crazy. So as we go through it, you know what I mean? And that's the thing, that whole out of sight, out of mind thing isn't obviously working, because, you know, we broke it off, and then, I mean, not to blame anybody, but it hasn't been good. So bringing it back in and figuring out, like you said, how do we do it? I mean, I don't know what caused the split off, or what law, or what federal law, or whatever. But I mean, we need to be able to compete, and so that's what I'd like to see going forward. Thank you.
I think it's important to note that we have kind of some of the same challenges on timeliness and sick times with our most expensive employees being our physicians. So we need to think about that in the contract too. We have a union contract where we love our providers. We want to take good care of our providers. We need to have the ability to monitor their work, right? So in most systems, employed physicians have a base salary, let's say it's $500,000, based on them hitting the units that they're supposed to. If they hit 80% of those units, if you're a Sutter patient, Sutter employee, your productivity is 80% of what their expectation is, your salary's at 80% of what their expectation is. That's the only way we're gonna drive growth, the way growth needs to be driven. If there is no penalty for essentially missing a day of work, if there's no, I understand that we're a county entity and there's some differences, but those differences for things like that don't make sense when the whole rest of the world, and not to mention Contra Costa, Alameda, all have productivity standards in their physician employment. So those things are really important because those contracts are coming up. I know I don't know exactly where we're going. We looked at our physician salaries, they're significant. The good news is they're where they need to be. They're on the high side of the norm because it's a challenge to recruit. We increased our physicians through a non-negotiate or a extension for 8.5% last year, which was significant when you look at it. We have to we have to understand the challenges that are before us and address them together. And it always feels like, you know what I'll just state that, really important.
So you're talking about just holding people accountable? I mean, it's pretty basic.
Well, I think you get what you ask for. And if you have a scenario where John Doe can see 5 patients an hour and Jane Doe can see 1 patient an hour, and the compensation is the same, if those things don't get addressed, your high performers either do one of 2 things: they leave, which we've seen significant out-migration from our physicians, and I think, unfortunately, we're going to see more, or they say, to hell with it, I'm going to see less patients too. And I'm not saying that what I'm telling you is very arbitrary. We kind of know it in our interaction with these docs, but it should be very specific that we have basic standards of productivity that need to be met. And if there is no consequence to not meeting them, in other words, if you decide that I have a doctor's appointment at 2 o'clock that I can't schedule on my day off, and there's no consequence for that, because once our physician comes in, he's paid for the day, I don't mind that he leaves for a doctor's appointment. We just shouldn't have to pay him that same rate for that, you know what I mean? For that kind of stuff.
And ultimately, our patients are impacted, right?
Right.
Because you're pushing them out on the schedule and they can't come to get their basic services. So that's kind of where the focus should be, right? What's best for our patients.
And I have an awful lot of unwinding to do there, because over the last 3-4 years, physicians in SJ Health were basically permitted to set their own schedules, come and go as they please. We're working to standardize that, but that's going to be a notice to the union and maybe a little bit of a fight. But we have, I think we've had some healthy turnover, but we need to hold them accountable. I'm all for a two-way street, but it can't be some of the abuses that I've seen now. I need standardization. And I know Dr. Dooley was working on that. We're working through labor relations to make sure that we properly notice and we move forward with these changes, because scheduling is a management right, and as well as us being efficient and focusing on the patient. And it's been too much focusing on whatever the provider wants to do.
Thank you. Are there any other questions specific to the hospital's presentation? Supervisor Ding?
There is. Where do I start? First off, on costs, I think we need to put a little blame on some other departments like the sheriff's department, the DAs. I've noticed your traumas are way down and their statistics for trauma cases and violent crime are down. So I think we need to do an transfer. The sheriffs are being a little too efficient. They're hurting our hospital. So
I think you're going to always see trauma.
that was a joke.
Yeah, but I'm just saying, you're going to see trauma peaks and spikes. I just want you to know that.
Thank you for clarifying that for the record.
There you go. I just wanted you to know, Mr. Castro, we hear you. I hear you when you're talking about retention of employees. And I'm hearing it from throughout, speaking for myself, I'm hearing it from other departments as well too. And it is very important and very expensive to hire, recruit, train employees, extremely expensive. And it is at the top of my list when we're discussing this. So thank you for bringing that up.
I guess I would just like to end by saying that we have an opportunity here that doesn't exist in most places. We have the clinics, we have the hospital, we have the health plan, we have behavioral health. There's not many scenarios in any other county that you see all of these pieces together. So, you know, the reason, again, one of the reasons I came is the opportunity for population health here is better than I've ever seen anywhere in California. I'm sure there's some, I don't know what it looks like in Santa Monica, but I suspect their 3 Medi-Cal patients are well taken care of. But we're not optimizing that. And I don't know, and I think that I've screamed at the hill at the top of the mountain so much that people are tired of me screaming, right? And I understand that. Everybody in this community deserves health care, right? We all agree with that. It's a right, not a privilege. And we have the opportunity to not only do it, but we have the opportunity to do it the way that it should be. We have the opportunity to set the example for the state. We really do. I don't think that's an overambitious want. And I think the only reason that we're not doing it is we are fighting amongst ourselves.
And that's got to stop. I think there's missed opportunity the last 3 years, this artificial separation from the hospital. At the end of the day, we all get a paycheck that says County of San Joaquin on the bottom line. We need to collaborate a lot more, partner. I'm not about the past, I'm about the future. And I think we have a lot of opportunities, specifically on the QIP and others integration. And I am thankful that we have a local initiative health plan here, because at the end of the day, we form the safety net. And I think the value of having the local initiative is to support our safety net and partner deeper with us.
And I've just got one more comment.
Please, Supervisor Dane.
Mr. Castro just opened the door on. All constituents within San Joaquin County deserve health care, not just Stockton. And so that's why the clinics are very valuable. And, this is, the county sometimes gets glass dome focused. And, the opportunities are out there, in Lodi, Lockford, Clements, Thornton, Linden, Morada, all over the place. So I want you guys to keep that in mind next time you shoot one of my puppies in Lodi.
So thank you, Supervisor Ding. Really good discussion, and we'll make sure that early next month we get together as a healthcare system and have a discussion, and then we can report it out at our next meeting.
For clarification,
Thank you, sir.
the last meeting we discussed that we do this quarterly, and in between we would, because again, the results that Abe gave you are not heck of a lot different than they were last month. And there's value here, but what we had talked about was the 2 months in between. We'd use as a strategy session between the three.
Yeah, so Mr. Castro, actually, you and Mr. Diederich and I discussed that, and then I discussed it with Mr. Wilverding, but I have not had a chance to connect with our two board members or put it on the public agenda for
perfect.
this meeting.
Perfect.
So we'll make sure I take care of that, and we'll talk about that next month.
Okay.
Thank you. Ms. Rivas, do we have any public comment?
There's no public comment.
Okay. Are there any committee comments that we have not already covered this morning? Anything anybody would like to add?
I would have some. It's been a very busy last 30 days with SJ Health. Very thankful. We had a very positive operational site visit by HRSA on January 23rd, 24th, 25th. There's 93 elements with 400 plus specific items. We only have preliminary findings on 5 of those, and they're able to be remediated. We'll get a final report from HRSA, and that will kick off a 14-day compliance resolution opportunity period. But the 5 items that are minor is we need to engage our patients on hours, so we're revising our patient survey to incorporate a question in that regards. One of our policies having to do with vaccines, seasonal influenza vaccines, we need to have the word required in there, so we're modifying that. Obviously, there's some contraindications, but that's easily fixable. We didn't have a quorum at our SJ Health meeting in the month of December, so we have a plan such that we can have a compliant quorum meeting every month. Some of our documents that we submitted to justify timely billing weren't actually billed within 14 days, so we're able to substitute that and working to make sure that providers close and we can bill documents in that 14-day time frame. But the largest one has to do with our required and optional services, or what's known as HRSA Form 5A. That's kind of deliverable I'm going to have, and it's a distinction of there's required and optional services, and they're in 3 columns. The health center performs them and pays for them. The health center contracts for them and pays for them. The health center refers and does not pay for them. And I'm going to be engaging with SJGH because 2 of these are hospital contracts for gyne oncology and a pediatric neurology that I need to have amended such that they're either we can join them, or we don't, or I would have to cancel the contracts. The other ones are getting into the county MOU, and I need to have a written agreement for radiology and diagnostic mammography. So I'm working with the hospital to make those amendments. Other things, February 15th, we had to submit our uniform data system report to HRSA, so we're able to do that. So 2 large deliverables were accomplished over the last 30 days. I would note that our former board chair, Rod Place, tendered a resignation on Saturday. We're having a senior leadership present to our board on the 27th with a variety of operational, employment, vendor and overhead issues, and having a robust discussion with them to inform us eventually standing up the liaison committee. A lot of work going into QIP. I think there'll be a positive pickup that you'll see represented on our January financials for prior years. We are doing a lot to add to the numerator and a lot of our measures. I do believe we'll be above where we were last year. And with that, I want to thank Dr. Doolittle. He's been doing a lot on QIP. He's been doing a lot on the provider recruitment. And that will be it. Thank you.
Thank you, Greg. Are there any other committee comments for this morning? Okay, if not, then we can adjourn at 9:48, and we will see everybody next month. Thank you very much.